So treating, this is my subtitle, is Treating Obsessive Compulsive Disorders, Does Neurobiology Help? I'm going to start off with this notion about how OCD, what it is and how severe it can be. So as you know, we tend to use this thing called the Diagnostic and Statistical Manual for Psychiatric Disorders. It's 5th edition. It's comes from the American Psychiatric Association. I'm not its greatest fan in the sense that I think it tends to resort too much to tick boxes, whereas, as I said earlier, we're really interested in people and how they experience these obsessions, compulsions, and how much they interfere with their lives. But in clinical trials and in the literature, we tend to use these criteria. So there are obsessions. Obsessions are your own thoughts. You recognize them as your own thoughts, and they're intrusive and troubling, and usually lead to an increase in autonomic arousal and anxiety. And to try and assuage that and reduce that anxiety, people then would engage in compulsions. And compulsions are rituals which are performed in a certain way. Sometimes those are very overt, things like hand washing and so forth, to try and deal with contamination obsessions. Sometimes they're just mental rituals, and they're actually quite tricky to treat. And I'll come back to that a little bit later. Of course, obsessions and compulsions are quite normal phenomena. All of us have them. And it's a matter of to what degree they cause distress and disablement. So the DSM says, well, these cause marked distress. Of course, distress is a little bit in the eye of the beholder, but I can assure you, and I'm sure many of you are more than aware of the extent to which distress can be caused by obsessive-compulsive phenomena, the obsessions, and how disabling and time-consuming the compulsions can be, and also how interfering they are with day-to-day functioning. I mean, some people become housebound completely. Some people really struggle to have effective, engaged lives because of the tyranny of OCD. So these obsessions, as I said, are recurrent, persistent thoughts, urges, images. They experience at some time intrusive, unwanted, and cause distress and anxiety. And there's various attempts to ignore or suppress these thoughts, sometimes to try and neutralize them, use alternate images, for example, or most commonly by performing a compulsive activities. So, as I said, feeling contamination and going and doing hand washing. And then the compulsions are these repetitive behaviors, or, as I said earlier, can be just mental acts, praying, counting, and so forth. And quite often these mental acts are associated with almost superstitious-like beliefs. Things like certain numbers are particularly important and relevant. So you perform a ritual in a certain way, in a certain number, certain colors, certain other images which might be brought into mind to try and neutralize or deal with obsessional thinking. And as I said, these mental acts or behaviors are aimed at trying to reduce anxiety or distress. Can occur in young people. In fact, it's not that uncommon as part of normal development, about the age of 11 or so, to have some at least overvalued ideas in this sort of domain. I remember myself when I was about that age having to kiss my mother goodnight on each cheek 13 times. Where I'd come up with that, goodness knows. But it was helpful for me and reassuring for me at the time, and I reassure myself that it was a normal developmental phenomenon. The obsessions and compulsions are time-consuming, as I've said, and the obsessive symptoms are not attributable to another cause, an illicit substance, for example, or another medical condition. This Criterion C is a very standard thing within the DSM. We don't have time to go into it too much, but it's an important thing to exclude. For example, so-called organic causes. Sometimes people have head injury and then have obsessive-compulsive phenomena. Sometimes obsessive-compulsive phenomena can occur as part of other disorders. So, for example, in autism spectrum disorder, for example, in some of the cuneiform disorders, especially one of the choreas. So these are important to include in your what we call the differential diagnosis. The DSM-5 also acknowledges that people mostly with OCDs have what we call insight. Insight, it's a very broad term actually, but essentially it says that you understand that these phenomena that you experience are abnormal on some level, and that your ritualized behaviors are excessive. That's essentially what insight is like in terms of OCD. But people on the video conference will be more than aware of either within themselves or sometimes within people that they know, that at times the intensity of the OCD can be so severe that it's actually really quite difficult to stand back from it and say, look, what I'm doing is excessive. You get so bundled up in it and so absolutely given into the ritualized behaviors that it's very difficult to stand back from it and stop doing the rituals. There's also a specifier which says that some people with OCD also have tics, that's little motor movements, some, for example, blinking of the eyes, little guttural movements and so forth. That might be a particular subtype of OCD and seems to have some treatment implications in that we quite often use antipsychotic medications added onto other medications to help if you have tic-related OCD. So this is from a leading researcher in the States looking at just 60 people with moderate to severe OCD and the impact on their lives and major impairment of social functioning, and that was correlations with the severity of illness and impaired role performance. And importantly, that was not just because of depression associated with OCD. OCD is often associated with depression, but independent of depression, it can impact your role performance and your quality of life. And this is a beautiful study from a husband and wife team from Scandinavia. And they followed up people who had been admitted to a hospital with OCD, followed them for 40 years. Beautiful work. Showed about half of them recovered. 20% though only completely recovered. So this is quite common. We see people with OCD, they manage to get treatment which alleviates their symptoms to some degree, but they still have, I always say to people, you don't kill the OCD monster. You manage to put him in a box, you put the lid on and you keep him there and hopefully he doesn't get out. Every now and then he'll try and push on the lid to try and get out. But mostly there's some what we call residual symptoms. So relatively low rate of complete recovery. Many had symptoms for a very long period of time. Now I should stress, and I don't want this to be too negative a story for you, because of course this is dealing with patients who had been unwell enough to land up in hospital with OCD. And of course a lot of people with OCD have much milder symptoms, and then the longitudinal course and the outcome for them is very much more favorable. But I do like to use this slide because it emphasizes to anybody who says that these disorders are not severe mental illnesses, then they need to look at this literature, because OCD, when it's very severe, is one of the most severe and disabling and distressing disorders I've ever seen in my clinical practice. And I really sympathize with any of you who have struggled with this for a long time, and also your partners and spouses and family members, because it can be very distressing, and sometimes the tyranny extends beyond the individual to the whole household. So what do we understand about the brain in OCD? And I'm going to make this fairly quick and simple, but I wanted to point out that we do know that people with OCD do have some increase in the blood flow, and that's an indicator of certain circuits in the brain which seem to be overworking. The way I talk to patients about that is to say, well, it's like the monster is getting in your head and speeding up the circuitry, and our job is to try and tone that down and switch that down and switch that back. And we do that with psychological treatments. We do that also with medications. And there's various strategies, as I said, psychological and pharmacological, and also psychosurgery and deep brain stimulation can sort of interrupt this circuitry, or at least slow the circuitry down. It is a normal circuit in the brain. It just, very crudely is sort of sped up and becomes a whirring, intrusive set of messages for you if you have OCD, and it's difficult to not pay attention. We also know that within the brain chemistry, there's these little chemicals called neurotransmitters, and they enable the brain to function. And the main ones are these monoamines, which are serotonin, noradrenaline, and dopamine. And I mean, there's others as well, but for today we'll stick mostly to those. And the one we're most interested in OCD is serotonin. So it does seem that there's some problem with the serotonin system. Now, serotonin system problems are not unique to OCD, of course. They also occur in depression, they also occur in other anxiety disorders. But the general notion is that there's too little serotonin and you need to increase that. And the medications which we tend to use for that are the so-called serotonin reuptake inhibitors. What they essentially do is to increase serotonin in the little, what we call the synaptic clefts, the little bridges between the nerve networks. And that can be very effective. Sometimes they can be essentially curative, but more often than not, they just sort of slow down that circuitry, and you still have residual symptoms, but it's more manageable. Interestingly, noradrenaline drugs, so those with just deal with noradrenaline within the brain, although they can be effective at antidepressants, don't seem to have anti-OCD effects. So it's an interesting phenomenon. But also we acknowledge that SSRIs or SRIs don't work for everybody. And we also know that dopamine and dopamine agents, like some of the so-called antipsychotics, can also be effective for some people with OCD. And there's a role for this dopamine D2 receptor also, interestingly. The D1 receptor, I won't go into the details of why that's interesting, but it's interesting. And then there's a proposed role for other pathways. So going away from it just being simply serotonin to saying, well, there's also importance of dopamine and this other pathway called glutamatergic pathways. So this is a brain. I borrowed this from Jim Gooden, and he didn't mind a bit. This is Jim's basal ganglia, and this is the hindbrain, the cerebellum. What we're talking about here is a circuitry which involves this part, the frontal cortex, as well as these more basal structures. And you can see these networks which are sort of sped up in OCD. If we look at it pictorially here, you can see these pathways which come from the midbrain, the brain stem, which is down this called the brain stem, which project up into the basal ganglia and then up to the thalamus and then through to the cortex. So this is this sort of circuitry. And we get inputs here from serotonin. We get inputs from dopamine through the substantia nigra. And then we also get these cortical circuits, which are not as well defined in terms of their neuromodulation, but we think that that glutamatergic pathways might be important. So I hope that wasn't too dense for you. I think it just gives a little representation of how the neurobiology seems to be mapping. But I'll get on to more clinically driven material now. So as I said, OCD itself can be a very disabling and difficult condition, and I suppose understandably it's associated with a lot of other disorders. Major depression is very common, and people not just getting depressed but also demoralized. So living with this can be really just demoralizing, and that can be the same for family members, by the way. There's quite a lot of overlap also with social anxiety disorder, also panic. Some people find the intrusions of their OCD are really so anxiogenic, so they feed anxiety in the brain so much that you can actually get to the verge of panic. And some people will say, I had one patient who had concern about contamination and found if she walked out and saw what she thought was a needle or blood, would actually have a panic attack in that context. There is an overlap with eating disorders, especially anorexia nervosa. There's also an overlap with substance abuse, including alcohol dependence. The other one, which Jim mentioned, which I don't have on this list, is an overlap with body dysmorphic disorder. Body dysmorphic disorder is classed along with obsessive-compulsive disorder, seen as part of the same grouping. And there the focus is on appearance, that people think that they're ugly, malformed, malshapen, and these become intrusive negative messages for the individual and lead them to a whole lot of ritualized behaviors, things like mirror checking, covering up behaviors, avoidance behaviors, and so forth. I won't talk specifically about body dysmorphic disorder any further unless there are questions about it, but it's a disorder I see a lot in my practice, and we've done a lot of research in. So I think what we're most interested in is really how we treat OCD. So I put this little chapter to a book together, and I thought it's not a bad overarching framework of general principles. And psychoeducation has to start the process. Without giving education, you don't get anywhere, and education also is very empowering. So Mental Health Foundation of Australia does have educational materials, which can be accessed through their website. The reason I'm putting family, as I said, often the family can be held ransom as part of the tyranny of OCD. And a lot of what family members get into is reassuring the person. Now, actually, reassurance seems natural, but it's actually not very helpful. It's a bit like a ritual in itself. So I had a patient who used to be concerned about leaving the electrical appliances on. So part of his treatment was to leave the house and not go back and check the electrical appliances. So what he used to do was when he got on the train to go to work, he would phone his mother and ask her to check, and she would say, yes, dear, everything's off and I've checked. And of course, then that wasn't really reassuring enough to quell the OCD monster, so he would phone up again and again and again incessantly. And it landed up being that his mum got irritated with the whole thing and said, you know, I'm sick of you phoning up and asking all this all the time, and I'm sick of giving you reassurance, and the reassurance doesn't really help. Well, as I said, it's natural for families to try and help their loved ones, and they don't like to see them distressed. But reassurance actually is not helpful. So it's a matter of working with the family to make sure that they're part of the treatment process, and part of that is not to give reassurance. I say to people, we need to not feed the OCD monster by giving into the reassurance seeking, and also if reassurance is sought from a family member, we need to have strategies to deal with that. I say to family members, say, David says no answer. David's me, and the reason for using that message is that it reinforces to the individual. It's not saying no answer because I don't love you and want to help you, but it's an important part of your treatment to remember that reassurance is not helpful, and we're actually tackling the OCD monster by not giving reassurance. Also says to David, if you want to be angry with somebody, you can be angry with David and you can take it out at him with the next session, rather than getting angry with me as your family member who loves you and is trying to help you. I said reasonable expectations of treatment, and remember, you know, OCD is often a long-term problem and can become very entrenched, and you need to set reasonable expectations in the sense that it's not something where there's a magic wand. It really just isn't, and it's hard work. It's treatable, absolutely. It's controllable, absolutely. We can get the OCD monster back in his box. But it takes time, because like any bully, he's going to try his damnedest to not be controlled. We need to treat what we call comorbidities. I've mentioned those things like depression and so forth, so that needs to be on the agenda. We talk about least restrictive environment, of course. Very important that we incorporate the patient's preferences, and that's important in terms of psychological versus medication treatments, although I think they should always be together, but also their preferences in terms of medications, because there are a range of medications which can be effective. So exposure response prevention, this is exposure and response prevention. So this is a very powerful method, a behavioral method, which was pioneered by Isaac Marks in London, who I actually worked with back in the day. And the idea here is that you expose yourself to the fear and you don't give into the usual response. So a graded exposure to, for example, contamination and not washing your hands. That's essentially the gist of it. But it needs to be done in a stepwise manner, and it needs to be done with proper support around it. And then SSRIs, so selective serotonin reuptake inhibitors, medications like Prozac and Lexapro and so forth, they're the first line medications usually, and I say it's best to use these together. Some people do very well with just exposure response prevention. I say to people, the SSRI isn't going to solve your problem, but it might make the whole journey a little bit easier. I use the message, which is akin to putting good octane fuel in your car engine. You know, that's the SSRI. It can help your engine run better, but you still have to drive the car. And the driving the car and getting out there and living a full life on the road of life takes your work, and your driving instructor might be seen as your psychologist who's supporting you with this and ensuring you drive really well and effectively, and using these exposure response prevention strategies. And of course, the therapeutic alliance is critical. I've said exposure response prevention is the mainstay of psychological treatments, which it is, and any treatment which doesn't include some elements of that, I think, is not going to really work. Sometimes we add cognitive elements, so as in cognitive behavior therapy, that just says we also challenge some of the thoughts. That can be helpful enough, and especially if you also have depression, for example, there's a lot of negative cognitions which can go with depression, so some of those elements can be helpful. But still, you need the behavioral therapy. Just cognitive therapy alone is not going to really work. We also are very interested now in acceptance commitment type therapy, the so-called third wave therapies, and this we've done a little bit of work on, and it can be quite a nice dialogue. It's more about acceptance than challenge and fighting, and can be a nice dialogue, but again, you still need this component. What about medications? Well, as I said, SSRIs are the mainstay and are very widely used. SNRIs, which target both serotonin and noradrenaline reuptake, can be effective, but they're not that much more effective than the SSRIs. And as I said, the noradrenaline doesn't seem to be an important component in and of itself. But sometimes these are used, sometimes they're seen as a little bit more powerful in terms of depression. So if people have quite severe depression as part of their OCD, we sometimes reach for these sorts of medications, things like Pristique, desvenlafaxine is the generic name, and so forth, Effexor, those sorts of drugs. And then finally, within this grouping is clomipramine. So clomipramine is an old, what's called tricyclic antidepressant, but it's been widely used in OCD, and some people see this as still the gold standard. One of the problems with it, of course, is that being an older drug, it does have potential for cardiac effects. So you do need to have an ECG to check your heart conduction, especially if you're using higher doses. It also, I found in my patients that it's often very difficult to tolerate. It has a lot of, because of dry mouth, constipation, very sedating. So it tends to be a medication, especially when you need higher doses, which can be difficult to tolerate. So these drugs really come to their fore. And then there are augmentation strategies. So the ones which are very common now are the so-called atypical antipsychotic medications. And as I said, there was early work looking at them, particularly in people with OCD and tics, but we're looking at it even broader in terms of use of these drugs, and they often can augment or build on the benefits which you get with the SSRI. That we don't use them alone. In fact, some of them, when they're used alone in OCD, can make OCD worse. So you've got to be careful about that. The ones which I tend to use most are what are called partial dopamine agonists. Don't worry too much about the terminology. The one which has the best evidence is a drug called aripiprazole. It's only available in Australia as an antipsychotic, and that's unfortunate because it's expensive if you use it for other indications. But it can be really helpful, usually at quite low dose for OCD. But there are others as well. Older drugs like haloperidol have been used, but also risperidone and other atypical antipsychotics. So these, the choice of exact agent is a bit based on the clinical experience. And also what the particular patient's preference is. I won't go through all of these in great detail because these are not actually, none of these, by the way, are on the pharmaceutical benefit scheme or on TGA approved in Australia for obsessive compulsive disorder. That's a shame because some of them can be effective, but they end up costing a lot of money because they're not on the PBS. What happens when these strategies don't work? Well, go back to ensuring that if the psychological therapies are being done properly, and the key really is to make sure that the messaging from the therapists is correct. The exposure needs to actually increase anxiety, and then the response prevention is staying with that anxiety until the anxiety subsides. If you don't get that right, you're not doing yourself any benefits. It's a bit like asking somebody to get you fit, but you just read the book, the fitness guide, and you don't actually go out and do the exercise. So exposure, as I say, stepwise graded exposure, it's a bit like working up towards getting yourself fit. Every step needs to challenge yourself a little bit. So the anxiety you experience needs to be a bit distressing for you. It's a matter of staying with that and waiting for it to subside. It's a bit like if you were trying to get fit, you would increase your exercise so that you get a little bit puffed and your muscles get a bit sore the next day. That means you're actually doing meaningful and useful exercise. You're not going to jump in with trying to run a marathon first up, though, with your exercise regime. Similarly, you're not going to be thrown in the deep end with the exposure response prevention. It's really a stepwise graded exposure, but each step needs to actually produce some anxiety, and that's a very, very important message. Combinations of pharmacological and psychological, I use that a lot. As I said, I think psychological is the mainstay, and people who are just giving medications, I don't think that's the right way to go. Some very good inpatient treatment programs can be very helpful, especially if people are particularly stuck. I did have an interesting example of this, though, because I had a patient with quite a lot of contamination fears, and she went into hospital, and when she came out, she had done quite nicely and had some benefits. But I said, how was it? And she said, well, you kept on telling me that I mustn't wash my hands so much, but in the hospital, all the signs everywhere were saying, wash your hands, wash your hands, wash your hands. So you've got to be a little bit careful about that. And I would say if you do choose an inpatient treatment option, it needs to be in a treatment center where they know what they're doing. And it's because all the messaging needs to be really spot on, and staff need to be able to give you encouragement and support, but not give into the reassurance which actually feeds the OCD monster. I'm going to talk a little bit later about deep brain stimulation and neurosurgery. I'm going to skip forward a little bit because I've spoken about most of these issues. I really wanted to move on to, so I've spoken about these matters mostly. I want to just move on to the other treatment processes, because I'm conscious there are lots of questions already and I'd like to really get to them. So one of the questions is ECT and shock therapy. That, as you know, it's still an effective treatment for severe depression, but really doesn't work for ECT. Sometimes people say, just give me ECT and it'll reset my brain. Well, it doesn't work like that. But we do use ECT for people with OCD if they have severe depression as well, and if that is what their treatment choice is, not for OCD itself. There's a lot of interest in TMS, transcranial magnetic stimulation. This is a little bit of a dated review from 2011. We've just updated that review, and I can share that paper with people if they're interested. So there's a lot more papers have come out now about TMS. One of the problems with the field is they've used different targets. So TMS can actually it uses a magnetic current to target particular parts of the brain. Usually in most TMS, it's the cortex, the outside shell of the brain. There's a lot of variation in the modalities. So it's high or low amplitude and voltage, and also exactly the part of the brain which is targeted. But there are some interesting and useful outcomes coming through, and people like Paul Fitzgerald, who's really a world-leading expert in TMS, has got some trials in this. Maybe the most exciting area in TMS is so-called deep TMS, and that's a very expensive machine, a bit of machinery which very few centers have, but sometimes that seems to, I think because it accesses deeper parts of the brain, that is really looking interesting in terms of clinical trials. Like neurosurgery can be helpful, and it's not as, I mean, it's obviously a hugely important set of decisions which need to be made if one's going to pursue these sorts of options. And in Australia, we don't really do neurosurgery for this indication anymore. Some centers in the States still do and have pretty good outcomes. Main reason we don't use the neurosurgery now is that we tend to use deep brain stimulation. So this is a reversible technique that 2 electrodes are put into the brain and targeting those deep structures in the brain, which seem to be part of that circuitry I told you about. We at St. Vincent's have a program. It's very laborious. It's a very big workup. It takes about 6 to 12 months to work people up, because we need to be absolutely sure that they're the right sort of person for it, that they understand all the procedures, that they understand it's also not just a magic wand. It takes also having psychological therapy on top of that, and often medications can be reduced but still are there. So this is our protocol. It's a research protocol. By the way, these are not treatments which are available just for anyone. It's part of a research process which is overseen by a research committee. And we have a collaboration with Austin Health, Swinburne University, and obviously St. Vincent's. And we do very extensive workup, and then we implant the person, and then we turn the stimulator on. And there's a lot of working around with the person to try and get the optimal settings. And that can be quite a laborious process in itself. My colleague Peter Bosnack, who's our clinical director here, does a lot of very fastidious work with this. So this is just to show you how it looks. We actually put a little burr hole and put the electrodes in, or at least our very skilled neurosurgeons do this. It's actually a very safe procedure. It's done with the person awake. Sometimes you can get an immediate response in the operating theatre. And then obviously it's linked up, and then the person's put to sleep because they need to burrow under the skin to put the battery cable and the battery, which is backpack, which is put under the clavicle. This is just an overview about our patients. So we've had 6 people. We map it using this thing called the Yale-Brown Obsessive-Compulsive Scale, which is a scale which looks at severity of OCD. And we've had, all of our patients have been very severely affected at baseline. And we've had a variable outcome. We've had some very, very, very good outcomes in 2 or 3 people. Some people in whom we've managed to reduce the intensity of the OCD. One person, unfortunately, didn't benefit at all. And eventually that person had their DBS switched off. So it shows that, again, it's not a panacea. If you look at the big data sets from Damien Denise, with whom we collaborate in Holland, he's shown similar outcomes to us, but in much bigger samples. About 50% of people actually respond in the sense that they get a very meaningful clinical response. About 30% of people do a little bit, do well, so their symptoms are reduced. but not to the level of response. And about 20% of people, unfortunately, don't respond. So I'm going to finish there. I'll leave this up just to talk about, how we think we might move forward with some of these parameters.